Really a pleasure for me to, really for all of us to welcome Dr. Ajay Kirtane to speak at Grand Rounds today. Ajay is the director of Columbia Interventional Cardiovascular Care, effectively the section chief of interventional cardiology. He is also professor of medicine at Columbia. He did his undergraduate at Princeton, went to medical school at Columbia, residency and chief residency at UCSF, before coming to the IDMC for cardiology fellowship and interventional cardiology fellowship. He worked with the likes of Dwayne. Dwayne was just finishing, I think, or had just recently finished fellowship with Peter, with Warren. Ajay is a real leader in interventional cardiology. He's led a number of randomized clinical trials, lover of important observational studies. He is a master educator. He effectively leads the TCT and really an incredible force for good in interventional cardiology. So really our pleasure to welcome Ajay to speak today.
Well, thanks for the kind introduction. And, for me, first of all, this building is awesome. It makes me really proud. And I was telling some of you that this is the white coat that was from my fellowship here. That's why it's a little yellow, I guess. But it was funny. I was thinking about coming up here, and just being invited back is a true honor. I really feel that way. And I was talking to my wife because I really can't find a ketchup bottle in the fridge without her. And I said, you know where my white coat from fellowship was? I mean, it was almost like a rhetorical question. And 3 minutes later, she had it. She's that organized and great. And so we started our family here, honestly. And this is the place where I learned to think as a clinician. I knew how to read the literature, but I really didn't know how to think as a clinician and apply what I learned from reading to seeing patients. And there were folks like Peter and others. I mean, every single attending I had has impacted me in a variety of ways. And so hopefully I'll tell you a little bit about the journey of how I think about coronary disease through this talk, but a lot of it came from the folks I learned it from. So this is like a good topic. I think it applies to everybody. Unfortunately, as we get older, you're going to get calls from family members, et cetera, about, do I need a cath? Do I need a CTA? Do I need a stent? And all those things will come up in the way I think about patients and how to manage them. And the bottom line for me with Grand Rounds is that it's not just about data, it's how do you apply that data to take care of the patients in front of you. So with that, I'll proceed. These are every disclosure relating to trials we enroll in, et cetera. You'll have them later through the CME office and have access to them. So I always like to start with a case for Grand Rounds, and this is a patient that I met quite some time ago. And I know there's probably some students and other folks in the audience. And one of the nicest things about interventional cardiology and many of the cardiovascular specialties is that we not only see patients in the lab, but we can follow them afterwards. And I still follow this patient. We can see them before. And a lot of the decisions we make are not just what to do in the lab, but when to take patients to the lab, how to treat them, et cetera. And that's what I really like about this field, and something that, Dwayne instilled upon me in a very formative part of my career. So this is a relatively young woman who had multiple issues in the past. Her EF was 30%. She had a PCI of the RCA in 2004, had heart failure, worsening dyspnea and exertion, had good guideline-directed medical therapy. And she was referred to us at Columbia, not to me, but to my heart failure colleagues for consideration of enrollment in stem cell trial or advanced heart failure therapies. And that was the summation of her past medical history. Interestingly, so I got a call from one of my heart failure colleagues who said, well, before we do any of that, I think she needs a cath again to see what's going on. And this entire dissociation of let's do advanced stem cells, et cetera, before relooking the anatomy, I think is kind of where I saw myself a few years after fellowship. I had trained really well, but what we started hearing a lot of is that there were unnecessary procedures going on. And in fact, it was better to do less than to more for our patients that came to us, because they really didn't need to come to us. This is from Newsweek in 2011. At that time, Newsweek was a very different magazine than it is now. But the bottom line is that the patient was the prey. The entire healthcare system were predatory. No was the word that could save the patient's life. And by the way, the healthcare budget, because we were really doing too much. So the question is as a young interventionalist coming out of fellowship, I thought we were going to doing good. I certainly didn't expect to be portrayed this way. So where did this come from? Well, the way this came about was because a lot of people started looking at where PCI was being done back during that time. And there was a gross variability in the penetrance of PCI. There were some places down here in Florida that had a really, really high incidence of PCI, adjusted for age, adjusted for other things like that. And there are some areas where there may not have been good access, but even just variability in practice, where you just didn't see a lot of PCI getting done. And the fact that there were these disparities, despite rational thought and clinical judgment, led people to believe that we were maybe doing shamuloplasties on patients, procedures that patients didn't need. And so there were a lot of efforts to try to regularize this. And this happened not just in cath, it happened in echo, happened in nuclear. The idea was to come up with a series of criteria by which it made sense to cath somebody with symptoms, risk factors. Okay, that makes sense. But somebody who just presents for an executive physical with inferior ischemia that we all know is the diaphragm doesn't need to go to the cath lab. And so these efforts, I think, largely regularized some of this practice. At the same time, there were trials coming out showing that we perhaps didn't need to do as many caths as we were doing. And what you sort of saw is that both at the hospital level and at the patient level, and Bobby's been involved in a lot of the observational tracking of what's gone on in this field, there was more regularization of this. And the rated appropriate cases went up. The rated inappropriate cases went down, although some of that could have been gaming. I do think there was a real change in evolution of thought. And that's important because we want to do procedures for the patients that need them, and we don't want to just do them because we can. So I kind of got interested in this and started looking at these appropriate use criteria, first from the eye of, wow, why are they trying to regulate me? But then second, because I was interested in where these efforts came about in the first place. And it turns out that the first efforts at appropriate use actually were not designed to identify overuse. They were designed to try to identify those patients who weren't getting care that they needed. So this was from LA County, looking at patients who were in hospitals and merited criteria for CABG or PCI or otherwise, and weren't really getting them. And if they didn't get them, that was associated with a greater mortality. Now, obviously, this is association, not causation, but nonetheless, these efforts would try to identify underuse and what was going on. There were other series of papers that came out. This is a paper from American Heart Journal in 2014, looking at folks that came in with non-STEMI, left main or three vessel disease on the angiogram. So pretty clear indications for coronary revascularization and gross variability in the penetrance of revascularization for those patients. Some hospitals were not revascularizing 30 or 40% or more of those patients, maybe because they were 90 and demented, but maybe because they weren't adequately trained to be able to deal with these types of cases. And so on the backdrop of this overuse of treating the obtuse marginal, the third obtuse marginal that didn't need to be treated, what we were sort of also noticing is there were patients coming to see us that had been turned down by surgeons, and they found their way to see us and were asking for multivesical revascularization, and we were able to do it. So we actually, one of our fellows who's a colleague at the MGH, Darshan Doshi, when he was a fellow, looked at this in an observational way and essentially identified patients that came to the hospital with a new onset of heart failure, admitted with heart failure, how frequently, not were they getting cath, but how frequently were they getting worked up for CAD? And it turns out that within 90 days, a third of them were getting worked up for CAD. You may say, well, this is underreporting. It's an observational database. So double that number. If it's 60%, it's still woefully low when you think about the number one cause of heart failure in the Northern Hemisphere is coronary artery disease. So just not making the diagnosis, there are these patients who are languishing. And so for me, it was obviously disconcerting to see all these people putting in stents in the third obtuse marginal and telling patients they were saving their life. But at the same time, it was equally disconcerting, perhaps more so, to see folks that really could have severe multivessel coronary disease that were not even getting diagnosed. And so why is it important? It's not just important for revascularization purposes. If you think about the prevalence of CAD in heart failure is 50 to 60%, basically guideline-directed medical therapy changes. You change the LDL target, you change what you might treat these patients with if you simply diagnose coronary disease and don't even necessarily treat it with a revascularization strategy. So this is a slide I borrowed from a good friend and colleague, Roxana Moran, whose daughter is right over there. Sorry to call you out, but it's so nice to see you. And basically the idea of revisiting the role of revascularization, whether it's for underuse or for overuse, is to really pick the right patients for the right reasons, use revascularization in an ischemia-driven way, and thereby optimize your patient outcomes. And by the way, you'll also optimize costs, because you may save money in the short term by doing a procedure that's not needed, but if the patient has a bad outcome, that's obviously bad for the system as well. So the way I'd like to break this down when I look at the evidence review is symptoms and prognosis. And interestingly, these are often called soft endpoints pejoratively, and then hard endpoints death or MI. But for many patients, actually, the symptoms are what's more relevant, and a minor difference in MI that's late, they might not even recognize. And so I find it kind of interesting how we sometimes term things those ways. So what's the data for symptoms? Well, if you looked at the New York Times in 2018, you see this interesting GIF or GIF. I don't know quite how to pronounce it. My kids sometimes pronounce it one way. I pronounce it a different way. But the bottom line is that you have a smiley face, a frowny face, and heart stents are useless for most stable patients, but they're still widely used. Why are so many patients agreeing to an expensive procedure and putting themselves at risk for a placebo effect? So again, as a young attending, this was disconcerting because I don't think that I put in procedures that don't work, do stents that don't work, but we needed to examine the data. So where did this come from? This came from a trial, a really, really interesting trial called the Orbita trial. And what's very interesting about it is that when it came out, there was those headlines. But what's happened since then is this entire series of research led by that group. And Rasha Alameh is a good friend. And this was her PhD project. And she subsequently done a series of other trials, and I'll show you some of that data as well, really trying to understand what is the effect that we have when we do a stent procedure on a patient. So in this trial, patients had to be having symptoms. In the UK system, they typically have 8 months of symptoms before they come to the cath lab. That's very different than the US. And they were treated on average with 3 or more antianginals. And on that backdrop, she exercised these patients. She then did a PCI versus a placebo PCI. That was the randomization, and then determined how much further patients could exercise. And what you saw from this trial is that the increment in exercise time, there was an increment with PCI, but it wasn't nearly what people would have expected, and it wasn't different from the placebo group. Now, one of the interesting things about this trial is that the total number of patients was small. It was 100 to 200 patients. The point of this trial was to basically see that PCI was associated with a benefit, and they were unable to do so. If you doubled the sample size, this would have been statistically significant. But it's not about the statistics that matter. What it really is about is the incremental change in exercise time really wasn't that great. And so we really needed to revisit what we were doing with PCI as a result. Now, they've gone on subsequently and done studies looking at how could you get patients angina free, and they did show that there were more patients who were free of angina with PCI compared to a placebo procedure. But I think most of us, myself included, needed to really say to ourselves, well, if you have single vessel disease, those were the patients in this trial, we're really not going to incrementally help them a whole lot over maximal medical therapy by doing a PCI on that patient. And that, I think for many of us, we had to sort of look ourselves in the mirror and understand that, but then live with it because that's the data. And it actually helps us manage patients a little bit better. So what was really important is that, to their credit, instead of just sort of saying PCI doesn't work, let's go with that New York Times headline, they did a series of other studies trying to understand what as the actual benefit of PCI. So this is one of them. It was published in JACC in 2018. And one of the things that came out with Orbita is that if the patient doesn't know that they've had their stenosis relieved, are they afraid to then exercise the full amount that they could? And so in this trial, which was not blinded, they took patients who had clear stenosis and then basically exercised them before and after the PCI. And the increment in exercise time this time was 67 seconds on the bicycle. The other thing that was interesting is that whereas previously patients stopped due to angina, after they opened up the stenosis, nobody stopped due to angina. They all stopped due to fatigue and dyspnea, and that was associated with an increase in the lactate. So there's clearly a physiologic effect, but how do you tie that physiologic effect to the symptom release effect? You need to do other studies, and that's exactly what they did. So the Orbita 2 trial, which just was published last year, they took patients off medicines entirely, because when you put people on medicines, you're obviously going to impact what the treatment effect is. So they took patients completely off their antianginals and randomly assigned them to PCI versus placebo. And they showed pretty definitively that PCI improved symptoms in that group. And what was really interesting is that in a subsequent follow-on paper, the patients that had typical angina, and we know from the chest pain guidelines, we're not supposed to talk about typical angina anymore, but it actually turns out that if you have typical angina with exertion, chest discomfort, et cetera, those are the most likely to have a benefit with PCI. So this makes clinical sense. It's kind of what we experience in practice, but a lot of kudos to them for doing the follow-on studies to figure this out. And even one other study that they just published in JACC this year was they actually looked at patients and their symptoms, inflated a balloon, asked them if it reproduced their symptoms, inflated a placebo balloon, so no inflation, asked them if it reproduced their symptoms. And if it did reproduce their symptoms, those were the patients most likely to have a benefit late. So clearly there's a reduction in terms of symptoms, but you have to pick the right patients. And it's not based upon their anatomy or anything else like that. It's really based upon how they feel to start off with. And as a clinician, taking that back to the clinic, if I have somebody who's telling me that basically every time they eat a meal, they get a little bit of stuff that sounds like reflux, it's unlikely that by dilating a stenosis in their coronary artery, I'm going to make the reflux better. On the other hand, if they tell me every time they walk down the street, they're getting angina, well, that's a different story. And those are the people most likely to benefit. So just an audience question so that everybody is awake and I can determine, because I'm getting over a cold, that I've been coherent. The Orbita program results are most consistent with the following statements, and there's three. There's no role for PCI for patients with stable ischemic heart disease and should be class 3 in the guidelines. This was actually what the editorial for Orbita said. So just going to put that out there. The second one, the symptomatic benefits of PCI over maximal medical therapy are modest for patients with single vessel stable ischemic heart disease. And the third part, PCI should be the default therapy for all stable ischemic heart disease patients with angiographically severe lesions. This is what, during many folks' fellowship training, people were saying to patients, not at this institution, but other places. This is what was being said. So I think most people know me. I'm kind of a middle of the road kind of guy. The answer is going to be in the middle. And we have to reconcile the fact that the symptomatic benefits are modest. We have to pick the right patients. And remember, the symptom improvement is going to correlate with the nature of the prior symptoms. What's interesting, though, is if we pick those right patients and we figure things out, we see some dissociations between what we do in clinical practice and the guidelines. So this is an earlier iteration of the guidelines where you really have to fail nitro, beta blockers, calcium channel blockers, even ranolazine before you consider revascularization to improve symptoms. And I think Orbita 2 in some respects turns this a little bit on its head, because if I'm a patient and I have very typical symptoms and I can treat the case very simply without a lot of risk, why should I have to fail all of these medical therapies? Especially because if you think about anti-anginals specifically, none of them affect prognosis. The only things that affect prognosis in stable ischemic heart disease are things like statins, aspirin, getting your LDL down, getting control of your diabetes, getting your control of your weight loss, GLP-1 agonists, et cetera. And so one of the things I've found from clinical practice, and this is when, I learned a little bit from Peter because, he's a consummate clinician. When you talk to patients, you can't add 5 medicines indiscriminately. Anybody know if I write a prescription? I'm a really good doctor. So if you write a prescription, how often the patient's actually going to fill it? It's about 2 and 3. And how often for even a Q-day medicine are they going to take it as prescribed if they filled it? It's about 2 and 3. So if you multiply those two probabilities together, you're about 50% adherence for any medicine you prescribe. So when we talk to patients and we add like a bucket list of medications and we don't explain to them why they're on them, or we don't say, your prognosis is going to be better as a result, because we can't in the case of anti-anginals, the likelihood they're actually going to take it is pretty low. And so for me, what I often do, especially if I revascularize them, is I horse trade. I say, we're going to get you off the beta blocker because your EF's normal. There's no evidence that you should be on it. But because I'm getting you off of this, I really want you to take the PCSK9 inhibitor. And that is a far more effective strategy than trying to just say, I'm the doctor, here's the prescription, take it, you're going to be great. So those types of things I think are very important. The reason I mention this is because if you take patients with symptoms and you revascularize them with PCI, all the randomized trials show you that you can reduce medication burden, less use of nitrates and courage, less use of calcium channel blockers. And what's also interesting is that if you pick the patients appropriately, you'll know who you need to treat. So this is a really interesting study from the Courage trial. Courage randomized patients to PCI plus medical therapy versus medical therapy alone, showed really no difference in outcomes between the two strategies. But what was interesting is that in the medical therapy arm, there were certain patients who had to cross over and have PCI. So who do you think those patients were? They were the patients that had the most severe symptoms. Because if you have very minor symptoms, I get chest discomfort once a month, why do I need to have a PCI? I can feel basically the same if I don't do it. On the other hand, if you have a lot of symptoms, you can try meds, but the patient is going to be dissatisfied and ultimately will cross over. And that's exactly what was shown within the trial. Those that had daily and weekly angina had much higher rates of crossover as a whole. In the ischemia trial, the exact same thing was shown among those who had to then go for angiography, because the ischemia trial was a randomization between cath versus no cath in patients with stable ischemic heart disease, just published this year. You see those patients that went to the cath lab were those that had more frequent angina. That was the most likely predictor of going to the cath lab. So it's basic clinical medicine 101. You're seeing patients in the office. Somebody has very minor symptoms. You know, from a CTA, they have that same OM3 lesion. Treat them with medical therapy. Emphasize the statins. They may or may not need antianginals, and that's fine. But if somebody's got very typical symptoms, proximal LAD disease on a CT scan, those people will be benefiting from going to the cath lab, ultimately revascularizing. You won't need antianginals, and then you can push the other things that help. This is just an analysis of that from ischemia itself, showing that in those patients that had weekly angina, you basically needed to treat 3 patients to render 1 angina free. But if you had no angina, you basically have to treat almost like an infinite number of patients, because if they don't have any angina, they're not going to feel better after you revascularize them. And these effects were durable over time. This is just the final part from ischemia, showing the exact same thing: less medication use with antianginals across the board, increase in DAPT usage with PCIs, so you have to mitigate the bleeding risk that's associated with that. Luckily, with our current stents, we can now drop this to 3 months or even 1 month in selected cases, so that becomes less of an issue. The final point I'll mention is we also have to be better doctors at discerning if our patients are truly having anginal symptoms. So this is a nice manuscript from Suzanne Arnold. She works at the Mid-America Heart Group. And what she did is they did a survey and asked the patients, are you having angina, using a validated instrument, the Seattle Angina Questionnaire. They then asked the physicians who were taking care of those patients, is your patient having angina? And what they found is that some physicians, these are individual physicians here with more than 5 visits, were completely concordant. They were really good doctors. But the majority of physicians actually underreported their patients' angina 40 to 50% of the time or more. Now, why is that? It's not because we're terrible doctors. It's because, you know, we're seeing a ton of patients in the office. We are dealing with Epic, and you ask somebody a question, are you having chest pain? They say no. And then they move on to the next thing. What I tend to do is, the one nice thing about being in a specialty like ours is that I don't have to focus on the healthcare maintenance and all that other stuff unless it comes up. And so I go deeper and I say, well, tell me, what do you do? Well, I don't really do anything. I sit on the couch all day. Well, then that question of chest pain is not a discerning question. You have to go beyond that. So you ask them, what about, do you have any pets at home? Yeah, I have a dog. Do you walk the dog, or does the dog walk you? That's what I always like to ask. Big dog, small dog type of question, because I have a dog. They may say, well, when I walk to the end of the driveway with the big dog, I can't really do it, so my wife walks the dog. So that patient probably is having angina, but they're just not telling you about it. And so you just have to go deeper and ask. And I'm not saying that it's not COPD or something else, but be a good clinician to try to figure out, and not be these doctors who are just thinking their patients are one way when the patients are actually a different way. So if you actually focus on the real patients with real symptoms, they may send you notes like this. And in the current environment where tweeting is easy and texts are easy, these types of messages, handwritten, I thank you for all of your help. It's a great feeling to be angina-free, from your grateful patient, who, by the way, is on less medications because we down titrate the antianginals afterwards, are great to see. And this is concordant with the guidelines, which say that it's class 1A to take patients with refractory angina despite medical therapy and revascularize them. I would argue, in the wake of Orbita 2, you don't really have to be refractory. This is a personal choice. But nonetheless, it's nice to see this validated in the guidelines, as opposed to that New York Times GIF that I showed you before. But it's really important to know we don't have to revascularize everybody. And this is a patient that I consulted on for a chronic total occlusion, who wrote me this nice note because I told him he didn't need anything. He said, thanks so much for taking the time to meet with me. You and your staff were kind. It was a great visit that was important to me and his family. Now, why was it important? It was important because he had a chronic total occlusion and he thought he was going to die of a heart attack because his artery was totally blocked. And what I just told him is, I said, the artery's been blocked. It has collateral supply. Your other arteries look fine. And there's actually a very low likelihood that that's going to happen to you. And that's why it was important, because nobody had ever explained that. And intuitively, he thought that this totally blocked artery was going to kill him. So it's important to talk to your patients and sort all that out. So beyond symptoms, I've hopefully convinced you that we can improve symptoms with revascularization of the right patient. Let's talk a little bit about prognosis. And this becomes a little bit more thorny. And the reason I say that is because most medical students are taught that for stable ischemic heart disease, there is no difference in prognosis with any revascularization strategy compared to medical therapy alone. That's kind of like gospel at this point. And I'll show you that that might be true for a broad swath of the population, but selected patients, that's actually not true. And the data actually goes the other way. So before I talk about revascularization, for prognosis, it's really important to talk about medical therapy and lifestyle modification. I will tell you that as an interventionalist in the lab, I'm very focused on the technical aspects of what I do. In the office and clinic, I spend the entire visit practically talking about this stuff because you have to convince people that it's important to lose weight. You have to convince somebody. Just yesterday, I was in clinic, why he needs to consider taking a GLP-1 agonist. He doesn't want to take a medicine, but he's overweight, he's gaining weight, and he knows he's eating badly, but he needs help. And so these things are really important. And I would like to say that, as an interventional cardiologist, most people identify intervention with the cath lab. I identify intervention with any intervention that works, whether that's gastric bypass surgery, whether it's GLP-1 agonists, whether it's smoking cessation, all of these things. Because for me, that's an intervention that's going to change the patient's life, in some cases more so than what I might do cosmetically in the cath lab. So these things we have to spend a lot of time about and explain each and every one to patients because they don't understand typically that if they feel fine, that I don't understand it. Frankly, I resisted taking a statin myself. That if I feel fine now, what I'm doing to manage that is going to affect me 10 years from now. That's a very, very important concept that we have to convey. And we know from studies like COURAGE that if we get these risk factors at goal, that's associated not just with improvements in quality of life, it's actually associated with mortality. We also know that we're terrible at doing it. In our society, this is patients with established CAD. Smoking cessation legislation has helped a lot. But if we look at things like physical activity, BMI, lipid control, it's pretty terrible. And one thing I'll ask all of you in the audience, how many of you have a plan today for what physical activity you're going to do today? Raise your hand. Not even Bobby. Bobby's like the fittest guy I know. But it's important. Like every day, have in your mind, what am I going to do? And the reason is that you're far more convincing. What's that? Nothing. That's right. You're far more convincing to your patients if you can draw upon your own examples than if you're kind of just fabricating them and making them up because it kind of seems like the right thing to do. And so, and I've found, like, for patients, who want to potentially lose weight, I've used things like calorie counting tracking devices. I tell them what the app is. I tell them I have no interest in the app, but use this app. It's going to work. So stuff like that, I think, is really important to do. And as I said, because I'm in a subspecialty, my office visit can be really, really focused. And for those that are in med school or in their training, that's one of the real benefits of being in subspecialty medicine is that I can really talk to them about those issues. I can ask them about their family. I can do all of that stuff, all within the confines of a visit and make it billable and epic at the same time. As far as how badly we do with this is just data. Every study shows the same thing. This is patients with established ASCVD, how frequently they're on a statin. It's like 50% of the time. I think there's a lot of misinformation in our world right now. The misinformation on statins is probably in excess of anything I've ever seen. It's good for PCSK9 inhibitors, which work well, but we need to basically, approach this with our patients. I had a patient 2 weeks ago tell me that, she wants to take a statin, but her daughter sent her a TikTok video showing that statins are terrible. And I was like, I'm really arguing against TikTok now. Is this really my life? But I have to do it because it's important for the patient. So I think that's important. So what about revascularization? Well, this is David Epstein. He writes for The Atlantic, and he published this in ProPublica in 2017. Stents for stable patients prevent 0 heart attacks and extend the lives of patients, a grand total of not at all. I was so incensed when I saw this that I actually emailed him, and we had a good correspondence back and forth. I sent him a version of this talk for him to listen to as well. He thanked me for it and said that's reasonable, but nonetheless, this was where this came from. So where does it come from? Well, the COURAGE trial, as I said, PCI plus medical therapy versus medical therapy alone, no difference in death or myocardial infarction through follow-up. And that was an important trial. But for me, it wasn't that surprising because in fellowship, I have to be honest with you, I would always tell patients that we can help your symptoms, but there's actually maybe an increased risk of MI during the procedure, not any benefit in terms of it. And so for me, this didn't really change very much, but I think it was important to, write editorials like that one you saw. But what's really important and gets missed in this is that it is important to diagnose and treat severe coronary artery disease from a prognostic standpoint, not just a symptomatic standpoint. So this is adapted from John Spertus. And if you want like a better exposition on this, Bobby wrote an editorial in Circulation a couple of years ago where he talks about this fact. And what it is when we look at the final line of the abstract of a manuscript or a randomized trial, there is a mean treatment effect. And that's an entire population of patients. What's the average treatment effect across that population? But we know as clinicians that there are patients that are not going to just have that mean treatment effect. There are those that are going to have a good effect. There are those that are going to have complications, a bad effect, and there are those that have a neutral effect. And what we do as clinicians is we try to isolate our therapies to those that are going to have a benefit and not give it to those that are going to have complications or other untoward effects. So what's the best arbiter of prognosis when it comes to coronary artery disease? Well, it turns out that it's anatomy. And this has been true historically for like 40 to 50 years. And this is from an earlier iteration of the ACC/AHA guidelines, where if you look at, for instance, a 55-year-old woman, and she's got 3 vessel disease with a 95% proximal LAD stenosis, her likelihood of surviving to her 60th birthday is 59%. That's horrible. And on the other hand, if it's single vessel disease, the likelihood is much, much higher. And the whole point of stress testing back in the day was to be able to identify the prognostically important disease and not indiscriminately cath and revascularize those people that didn't have prognostically important disease. That's how stress testing was invented. Could we non-invasively determine if somebody has prognostically important disease? So the anatomy is a really, really important thing. And in the CT era, this has also been borne out. If we look at data, this is a large study from Denmark. Basically, if you have obstructive and extensive disease, not just a lot of plaque, but is it obstructive, that's associated with a much greater likelihood of death or MI, and MI specifically. That's kind of why we go into cardiology, to prevent heart attacks. And also, this is a nice study from the past year in the European Heart Journal. If you look at on the left of the slide, those findings on CTA that are associated with the worst outcomes are actually things like severe stenosis and the presence of multivessel disease. Other things certainly impact prognosis and need to be treated, but pound for pound, it's those things that matter. So prognosis does matter. So why do we get this teaching that prognosis doesn't matter? And why in the United States do you have to sort of fail a bunch of tests before you ultimately go to the cath lab to figure out what your anatomy is? The reason is because frankly, in the United States, we cath the wrong people. So our system is one that's set up where you can literally have an executive physical, inferior ischemia from the diaphragm, and you end up in the cath lab. Versus other systems that have a more prescriptive approach to getting to the cath lab, where you see differences in prevalence. And so this is a really nice paper that I found in JAMA in 2013, looking at the prevalence, the bottom line here, of left main or 3 vessel disease in 2 different systems, New York State, where I'm from, and Ontario. And you see there's basically double the prevalence of left main or 3 vessel disease in Ontario as it is in the United States or in New York specifically. So if you just cath everybody indiscriminately, you're getting a population that doesn't need to be in the cath lab and those that don't have severe disease. Versus if you focus on those with the most severe symptoms who have to, in some cases, wait to get to the cath lab, you're going to get a more enriched population. And those are honestly the patients we need to focus on for prognosis. So why do I say this? Well, the reason I say it is because there are randomized trials in left main disease, in multivessel disease, that demonstrate mortality benefits associated with revascularization of those high-risk subsets. Now, the first thing that someone will say to me is, well, these are really old studies. I mean, you're taking stuff from 1994. That's last millennium. Yeah, that's when I graduated med school. It's true, but it is last millennium. So what about medical therapy has changed, and can we believe these studies? Well, first, I would say I would not want you to roll the dice on my left main lesion, and because we now have statins that can potentially prevent this. So for left main disease, I think the jury's out. For multivessel disease, we'll see, but I think it's important to do this in a more contemporary way. And that's exactly what the ischemia trial did. So I'll review this in a little bit of detail. Ischemia basically sought to enroll about 8,800 patients. It ultimately did enroll 5,000 patients and had to stop early because of funding issues. And the idea here was to randomize patients to a cath versus no cath strategy. And these patients had to have high-risk stress tests. The majority of these stress tests were actually treadmill stress tests because the trial was international and they didn't actually have as much nuclear or other things like that. But the question was, could you prevent adverse events by cathing people early? Now, it's very important to recognize that in the ischemia trial, patients had a blinded CTA up front. And the reason they had a blinded CTA was because if they had left main disease, it was not ethical to randomize that patient to no cath versus cath. And that was about 8% of patients, which is not small. If you're going to apply ischemia to your patient population, 10% of the patients that have these features are going to have left main disease. That's a problem. So you have to think about that. But nonetheless, I think it's reasonable to test this hypothesis, and that's what they did. The follow-up in the trial, the original follow-up was a median follow-up to 3.3 years, which is not a long time for prognosis, and they've now published subsequent extended duration follow-up. This was the primary endpoint of the trial, which really showed no difference between the two arms. There's, of course, an increase in adverse events early from the cath strategy because it's invasive, and then the curves cross, but there's no difference over time. But one of the things that I don't think a lot of people know about the ischemia trial is that while the primary endpoint was negative, the trial was originally designed to look at cardiovascular death or myocardial infarction. And what was really interesting is that while there was an excess risk up front, because you're going to the cath lab and you're doing surgery and PCI, at 4 years, there's a statistically significant reduction in cardiovascular death or MI associated with the cath strategy. Most people don't know this. They think the ischemia trial is a stone cold negative trial. Well, it turns out that it's actually not. I mean, this is not powered for this endpoint, but the original hypothesis was that cathing patients would lead to a lower rate of cardiovascular death or MI. And at 4 years, that's actually what they showed. So where does this come from? How are you reducing death or MI? How are you reducing any outcome by going to the cath lab? Well, surgery, obviously with severe multivessel disease, there's data, I showed you that before, but even PCI, there are meta-analyses showing that you can reduce spontaneous MI by doing a strategy of PCI. Now you incur an upfront risk of paraprocedural MI, but spontaneous MI is lower. And within the ischemia trial, you'd want to know, is this type 2 MI? What kind of MI is it? Well, it's actually type 1 MI. It's STEMI. And there's a lower rate across the board in the invasively managed arm than it is in the conservative arm. And that's something that's going to be hard to reconcile. And the guidelines committee struggled with this because you're clearly showing a reduction in late MI by this strategy of going to the cath lab. So who should we be revascularizing? That's the big question. In addition, if you look in the primary publication in the New England Journal Supplement, the Bayesian analysis of this shows you that at 1 year, there's an increased risk. At 3 years, it's basically a wash to starting to favor the invasive arm. And at 5 years, there's a pretty clear reduction in cardiovascular death or MI with the invasive arm. And this, in my opinion, is because we're diagnosing the bad multivessel disease. So if you look at the later follow-up from the trial, interestingly, cardiovascular death is reduced. It's offset by an increase in non-cardiovascular mortality. But this finding of a reduction in cardiovascular death by going to the cath lab is driven entirely by the multivessel disease patients, which brings us back to the historical thing that we were trying to figure out with stress testing in the first place. Let's diagnose multivessel coronary disease. And what was just published this year in your intervention by Shripal Bangalore was if you look at patients that had 3 vessel disease on the coronary CTA, and they were revascularized either with PCI or with CABG, there's a reduction in cardiovascular death or MI and an improvement in angina in those patients. So the idea is it's not even prox-LAD, it's multivessel coronary disease that you can diagnose and appropriately revascularize, and you will find a prognostic benefit for it. So the audience question number 2 is with regards to the prognostic benefits of revascularization. What we learned in medical school, there's no patients for which coronary revascularization has been shown to have a prognostic benefit. The second one, the prognostic benefits of revascularization are manifest in highest risk patients, but take time to offset the procedural risk. And number 3, revascularization unequivocally saves lives for most patients, irrespective of baseline risk. The answer is obviously in the middle. It's the second one. And I think that this issue of offsetting risk is really important because it fits into our calculus for the risk benefit of every procedure we do. We know that we can potentially help patients with multivessel disease by defining their anatomy and revascularizing them, but how safe is it to do the revascularization? Are we incurring excessive risks in doing that, such as that we're going to offset that longer term benefit that they ultimately have? And the guidelines committee reads it the same way. They made it a 2A indication to revascularize patients with multivessel disease to lower the risk of cardiovascular events such as spontaneous MI, revascularizations, or cardiac death, which is a big deal because this is not what, at least, I remember when I did precepting for medical students, not what they're teaching in medical school. And so I think this needs to be revised. And it's really nice to have the ischemia trial to draw on in that regard. Now, I will say just a quick word, because this paper came out this year. There was a trial of preventive PCI, because you could argue that what I'm telling you is we need to revascularize everybody. And I'm not saying that. In fact, there was a trial that was billed as a trial that you could prevent MI events and prevent events by revascularizing patients preemptively. This is called the PREVENT trial. It was in the Lancet. Sorry, these bars are not accurate. But it's a good example of the limitations of clinical trials, where basically the primary composite endpoint favored the preventive PCI strategy, but it was entirely driven not by death, 7 versus 8 events, not by MI, 5 versus 8 events, but entirely driven by ischemia-driven revascularization. So what the premise of this trial was is upfront, we're going to take lesions that are non-obstructive, we're going to do PCI on them, and we're going to try to prevent events by doing it. Well, what they actually showed is that by not treating them up front, you could avoid 782 revascularizations because there was no risk of MI or death from leaving them alone. So the problem with the argument that I'm making is that there are people who use these arguments to sort of start justifying stenting everything. And we really don't want to come back to where we were before with the shamuloplasty era. What we really want to do is do it rationally. And so you can't use data like this to try to make it into something it's not. So where does this leave me? And then I'll sort of conclude in the last 10 minutes or so with what are some of our areas of interest of study. So this is the first thing. This is how I incorporate ischemia into my daily practice. I have a dot phrase, AJK ischemia, my initials ischemia. And, EPIC can be a pain, but when you just type those words and this comes out, it's actually really nice. And the point is that these are for patients that are less symptomatic. We had an extensive discussion on the basis of ischemia. I see no reason to rush to the cath lab and revascularize. What might change this, because I want to hedge so that the medical legal stuff is okay. But then basically I say I can never predict a future event, but I don't think there's any data that leads me to believe that I'm going to benefit this patient by taking to the cath lab. And so if any of you want this, happy to share it with you. I can email it to you or otherwise. But this is what I do in clinical practice. That's how I use the trial. But back to this issue of underuse and how do we treat the patients that need our help the most. This is a white paper we published in 2016, so it's coming up on 10 years. And the idea was to get away from the unnecessary cases, but to focus instead on those patients that had the most to lose, those that had severe anatomy, severe symptoms, and how are we going to treat these patients safely and effectively. Well, first, I want to emphasize we still need to be better at medical therapy. So for our folks that were coming to our cath lab for CTO intervention, atherectomy, or left main intervention, a medical student looked at the data that we had and showed that 43% of them had LDLs less than 70. So they were coming for high-end angioplasty and stenting, and we weren't doing the basics. So what did we do as a result of this? Well, what we basically did is for our pre-cath labs, we included a lipid panel in the pre-cath labs. So everybody gets a CBC and INR and all that other stuff because we don't want to do procedures that are going to be risky. But why don't they get a lipid panel? Because even if I do a cath that shows non-obstructive disease, I'm not just going to say you're fine. I can actually optimize your lipids at that time. And so this is a viewpoint we wrote in JAMA Cardiology. It should be obvious that we're doing this, but most people don't. Most people don't in their cath report have a recommendation for guideline directed lipid therapy. And so we do as a result of this. Now, as far as the anatomy itself and how do we treat it, we have to train. And there's a lot of stuff people need to learn. And this is what we call the chip space of coronary intervention. You really need to become an expert in coronary intervention because the cases we're seeing now are more and more complex. And with these techniques, you need to be able to figure this out. So just an example of this is a patient that had a prior bypass surgery, kept having restenosis at this anastomotic site of the rema to the right coronary artery, but kept being managed medically because this is what his right coronary artery looked like. And that was unapproachable to the folks that were seeing him. And so he actually somehow came to see me, and we had treated the anastomosis once already and it restenosed. And so we said, well, why don't we just treat this native coronary artery? And he said, well, they told me they couldn't treat it because as you can see here, hold on, there's not really much of a course of it. But with basic techniques, we call them dual injections, injecting down the rema and the right at the same time, you can define the course of the artery, you can anchor your guide in that top branch. And without getting too technical, this was actually the first case of dissection reentry that I did. And we basically found our way down the right coronary artery, re-entered, got distal wire position, revascularized him. And I still see him, 8 to 10 years later, and he's angina free. We cut him off his medicines, focused instead on the lipid lowering therapy, et cetera. So the problem is that in the United States, the average operator does one angioplasty a week. Did you know that? It's kind of scary. If you have a STEMI somewhere, the likelihood is that the operator doing your STEMI is doing one of these a week. And it's not possible for those operators to do those types of cases. And so what we do in our cath lab is we actually have a team that works on these cases. And because we're not in an RVU-based system, what we end up doing is whenever somebody comes to the Columbia Cath Lab with left main or CTO, they scrub with one of the operators that does these cases. And as a result, if you come to the Columbia Cath Lab, you're going to get a regularized level of care, irrespective of who the primary operator was on the case. And this matters because this is the busiest cath lab in the world, Fuwai Hospital in China, in Beijing. And in the same lab, if you take a high volume operator treating a left main versus a lower volume operator, you basically have associated reductions in cardiac death and overall mortality, despite the fact that the highest volume folks are probably taking on more challenging cases. So volume does matter, expertise matters. We have to figure out systems where we can kind of regularize this across the board. I know variability is of keen interest to many of the folks here in this room, Bobby especially. And this is an important slide from the Syntax trial. It was a randomized trial of surgery versus PCI. Each site is a bubble. This site here had a rate of MACE for CABG of 40% and 10% with stents. The red site on the top left, 50% with PCI, 0% for CABG. Of course, there's confidence intervals around these things, but it suggests that if you happen to have the exact same anatomy and you came to this site here, you'd probably want to have PCI, not CABG. And we need to be honest about these outcomes and how we are. And in the guidelines, it actually tells us that we need to spend sufficient time to engage in conversation with our patients, allowing for second opinions. We should discuss specific risks. We should provide information on operator expertise and volume. It was actually a sidebar conversation with Bobby yesterday with, can you be a CTO operator and not see patients in clinic? And Bobby said, I don't think you can, because you're not really discussing adequately with the patient what the risks and benefits are if you just show up on the day of the procedure. So these things are very, very important. So my last slide before my take-home message is to show you the patient-oriented thing. And it's funny to think that this guy is not controversial anymore, but that's the state of what's going on. He had a procedure that was deemed an unnecessary procedure. American medicine at its worst, the poster child for inappropriate use of stenting. And so what he actually had was he was pretty much asymptomatic, but as an avid cyclist riding 40 miles out in the wilderness, et cetera, mountain biking, and he had a lesion that was treated. And so it comes out subsequently what the lesion was, and he was being asked at a meeting, what did you think of all these people saying this stuff about you? And he had a penchant for these one-liners that were often at his own expense. But in this case, it was the best one-liner possible. And it was like, they can say whatever they want. It wasn't their LAD. So the idea is this has to be personalized. We have to be good physicians and really titrate our therapies to what the patient needs. So what did I attempt to convey today? Well, first, that coronary disease and the syndromes associated with it should be treated with therapies aimed at symptom relief and prognostic benefit. They shouldn't be treated because it helps someone's bottom line, because it feels good to do a PCI or anything else like that. The location and severity of anatomic disease, the type and severity of symptoms, and the risk of the patient are often going to dictate the benefits of revascularization, but it has to be informed by a healthy dose of common sense. You're never going to send somebody for a crazy complex CTO if their symptoms are minimal, or you shouldn't. And so that's important to recognize. I also want to point out that I do think interventional cardiology can be as cerebral as it is technical. We like interventions that work, not just interventions that occur in the cath lab. And that's a fundamental thing I'd like to instill in the trainees. And then finally, for me personally, it really feels great to be back at the place that taught me how to think about clinical medicine. I think that the ability to thoughtfully apply and communicate our clinical judgment informed by evidence-based medicine that evolves is our fundamental responsibility as clinicians. I think we should take it seriously, feel like it's a privilege, which is kind of how I feel about it. And I just want to thank so many of you here who helped that be something formative in me. So thanks, everybody. Yeah, so the question for those on the Zoom is, how do we know truly the natural history of, for instance, a prox-LAD lesion? Because there's a lot of confounders. I have a lot of hope for some of the serial CT studies that will be done. One of the problems, we use a lot of CTA. I don't know if it's similar up here, but after ischemia came out, probably the single biggest benefit that we felt on the clinical level was it became much easier to get coronary CTA approved. The problem is that people freak out over a 50% or 60% lesion, and they demand a cath. The radiologist tells the patient they need a cath, et cetera. Obviously that has to be regularized, and heart flow and things like that can help. But my feeling is that there are a lot of studies being done now with CT and then follow-on CTs, and then we'll hopefully gain some understanding of it. Also, the relationship of that to various plaque characteristics may help in addition, because the truth is that if you have a 50-60% prox LAD, even 60-70% of the patient's asymptomatic, treat it medically. And I saw one woman in the office yesterday has two vessel disease and osteal 70% LAD, and we've been treating it medically, and she's fine. I did do a stress echo just to be sure that she's truly okay. Why did I do that? Maybe I don't need to, but it was kind of treating myself a little bit. But yeah, these things may arrest over time, especially with the more potent lipid-lowering agents that we have.
In terms of volume operator, how do you think about this in the current era? A lot of people getting interventional cardiology and retiring and whatnot. And then also, how do you can be very active in the cath lab installing for how do you think about reorganizing this volume criteria? Because this also takes out of the fellows who all want to hit their numbers, but when those numbers were set, they weren't doing 25 CTOs that take up a whole half day versus 5 PCIs. I think these numbers sometimes get skewed that they want angioplasty, but maybe they were
No, and I mean, I always tell the fellows, especially for our programs, I mean, they're folks that just want to get their PCI numbers. And I sort of tell them in our fellowship orientation for interviews, like, if that's all you care about, you shouldn't come to our place, because a type A lesion RCA is less learning than like a multivessel FFR, where you're kind of debating and thinking about what to do with the case, et cetera. Add on the imaging component, et cetera. I think you just have to be honest. We do train too many interventional fellows in the U.S. But what's interesting is, I've been hearing since I left fellowship that the old dudes were going to retire, and they're definitely all old dudes. They're not women. So I kept hearing that the old dudes were going to retire, and they never did until now. They're actually retiring at this point. Fully respecting them, and they should have. I have a lot of respect for my elders, but I think that there may be operator openings. I do think coronary, though, is still bread and butter. There's a lot of structural interventionalists, for instance, who don't want to take call and don't want to do coronaries. I think that's a mistake, just given the prevalence of what goes on. And I almost view myself as an interventional cardiologist. I'm a specialist on plaque, and that because I do peripherals too. And so that whole athero plaque component, we even changed, the byline of TCT this year was from intervention to prevention, because that component is really important in terms of what we do. So I think for me, the most important thing is the cognitive stuff. But the hands, you have to restrict some of it. And we have a great place where some people do structural, some people do endo, some people do complex coronary, so everybody's happy. But it's hard to do that at a lot of other places.
How do you think about you integrate the potential, like, would you risk somebody who's going to go out and push themselves really hard and be a student every time they go out and work hard, work out hard? None of us have any idea about your scheme in your finding the next.
Yeah.
You integrate that in your decision if you want to work out at a high level.
I do. So the question for the Zoom folks is that, how do you integrate the arrhythmic risk, and using the George Bush as an example? I mean, for me, that's, I think, the fundamental problem with that question. And that's why I said that lady I was talking about, I did a stress echo on her. It was mainly for arrhythmic risk. It wasn't to look for the ischemic component. If you look at the ischemia trial, though, the likelihood of dropping dead in that conservative arm is very low, and it's identical to the other arm. So from a population basis, it's low, but it's just vigorous exercise, stuff like that. I have another case that I often show of a patient who, liked to deep sea swim. And he goes, like well into the ocean of the Jersey Shore and wants to swim, and he's got this disease. And I'm like, look, man, if you happen to have an arrhythmia, there's nobody coming out and defibrillating you there. And so I just discussed it with him. I said, I don't really know, but I would err on the side of treatment, especially if it's, a focal-ish type of stent. I'm not talking about rotablating the LAD and putting in 40 millimeters of stent. Focal thing can be done safely. In those cases, I err on that side, but I'm honest with the patient. And the problem with being honest with the patient is always worried. So they're always going to err on the side of doing stuff. In fact, it's sometimes harder to convince them not to. But there's also a lot of non-interventional cardiologists who have, the courage of the non-combatant, big time. And they're just like, oh no, you don't need any of this stuff. And you got to think about your mom or your dad in front of you. What would you want?
So you talked about underutilization disparities. We talked about how to improve access to
Yeah. So the question was underutilization and disparity. So, I used to think it's impossible because like there's this zone of repugnance. You're never going to refer to like the person across the street because doing so would be an admission that they're better than you or something like that. But I wonder if some of the stuff that's going on now, in, for instance, in AS with AI diagnostics and ability to sort of diagnose AS without even listening to the patient with a stethoscope. So we have a pilot program going on at Columbia whereby the EKG you can sort of come up with markers. That type of thing might allow patients better access. Because what really frustrates me is I always ask patients, all of my fellows know, the first question we ask the patient is, how did they come to see me? And it's just random sometimes. They just a friend of a friend of a friend, and you see them with horrible anatomy, and you worry about how many people like that are walking around that just don't have that Rolodex. So I hope that there are ways around that. I think systems are helpful in that regard. So we have a 10 hospital system. We don't, as I said, there's not an RVU based model. So folks can refer in if they need to. We'll do cases with them if they need to. So my hope is that can happen. But it's hard in the current US environment. There was another question. Yeah.
That was great, Ajay. You have that graph that you showed about variability in outcomes or complication rates for PCI and CABG for high centile score patients. I'm wondering if there's a similar distribution in complication rates for patients with fully stable coronary ischemic disease by either center or individual specialists. Because it would seem to me that the decision on whether you revascularize stable ischemic heart disease is not just a function of who the patient is, but also the procedural distance. And do we want to have this conversation that the economic pressures are such that people doing the most stable ischemic heart disease are probably the ones with skill?
Yeah, so good question. So the question was about, is there variability in operators, especially with stable ischemic heart disease, in terms of who's doing what and what the outcomes are? The thing is that it's actually remarkably safe to stent patients with stable ischemic heart disease, especially if you get more experience and you don't take on things that you can't take on. So really hard to demonstrate true outcome issues associated with that. There are ways, and I know Bobby, and you may have been involved in this as well, that the recent paper on failure to rescue. So if a complication occurs, how good are you of getting out of that situation? Because that's really what matters. But it's hard. I do think in the CTO space, when you're taking on complex anatomy, complex cases, you can then start to discern some of these things. And it's pretty obvious, pretty clearly, like who's good and who's not good. I even know, like, if I look at films in the New York area, I've been there for almost 20 years now, like if where it was done, who did it, tells me a lot about the quality of the PCI before I even look at the films. And the same thing is true with the use of imaging. So imaging now is going to soon have a guideline and recommendation, I think, in the US guidelines. And so are people using imaging? Is that a surrogate of good outcomes? We just don't know. But it's hard, and you just don't know. It's like with any surgical procedure, how do you figure out who the surgeon is going to be? You ask around, but you can't really figure out their outcomes. It's really just, the word of mouth for a lot of it.
Is failure to rescue a function of individuals or lab?
Both. The failure to rescue can be, I think it's individual, but also systems as well. And it's also one of the interesting paradoxical things is that, like hemodynamic support with the Impella device, people always ask, is there overuse and underuse? And it's yes, there's both. And there are also cases where in our lab, you won't need to use it because our lab is really good. But if I was doing that same case in another lab with an inexperienced staff, I would use it because they just are not going to react with the same time. So it varies a lot. Well, thanks everybody for having me. Really a pleasure.